Warm welcome to another session of Pediatric Orthopedic Advanced Learning Session. We are really thankful to international experts who agree to share their experience and knowledge with our fellows. And it's not only fellows, because if we see the audience, there are a lot many professors and practicing pediatric orthopedic surgeons, senior practicing pediatric orthopedic surgeon also as an audience. So we are very thankful to all the international speaker and particular to Reid Nichols for accepting our invitation. The topic for the today's talk is not a routine talk, and that's a lower limb problems in arthrogryposis. Before I hand over to Reid, I would request Professor Rujuta to introduce our speaker. Over to you, Rujuta.
Thank you, Dhiren Bhai. And it's my absolute pleasure to introduce Reid to all of y'all. Louise Reid Nichols is a pediatric orthopedic surgeon and serves as the co-director of the Clubfoot Clinic and the Arthrogryposis program at the Nemours Institute, Delaware. She did her undergraduation from the prestigious Johns Hopkins University School of Nursing, and then earned a medical degree from Northeastern Ohio University College of Medicine. And after graduating in orthopedic surgery from Medical Center Brooklyn, she's also completed a fellowship in limb reconstruction at the International Center of Limb Deformity in Baltimore under the supervision of John Herzenberg. She received advanced training in the management of club feet and completed a fellowship in pediatric orthopedics at Nemours as well. She's active in many societies, including the Pediatric Society of North America, Limb Lengthenings and Reconstruction Society, the American Academy of Orthopedic Surgeons, and Ruth Jackson's Orthopedic Society. Dr. Nichols' interests include limb deformity, reconstruction, clubfoot, and pediatric trauma. But what I would want to particularly mention is the wisdom that I have seen her demonstrate in her clinics. She's a tough girl, takes on tough jobs, and she does them well. So she's the perfect example of woman power with a lot of balance and a big heart for her patients. So over to you, Reid, and we hope to share from your wisdom and really grow together.
Thank you for the kind introduction. It was so fun to have you here at Nemours. So I'm a little bit south of New York City, on the East Coast of the United States, and I am thrilled to be here to talk with you guys. Arthrogryposis is a really unique problem, and it is a tough problem, and so I'm going to try to give you my kind of the way I do it. So here we go. If I can get this. So I don't have any disclosures that are pertinent to this talk. The only thing I would like to let you know is that I am going to use my patients with their eyes wide open. The families have given me permission to do this. So we're going to start with the basics. I really think it's important that we know what the role of a multidisciplinary team is in the management of this problem, because it is not just one limb, one joint. I want you to kind of see some of the common problems that we encounter with these kids. And this is the takeaway. We can fix it, but should we fix it? I think we need to mute some other people, if you don't mind. And I'm going to do this as sort of to give you a background, and then we're going to take some cases and show you some of the solutions that I've come up with. But it's always about what the kid and the family wants. And then I want to, hopefully I'll get to kind of what the future holds in my eyes. All right. So
Reid, we are not able to see your slides. Yeah, you just need to share the screen.
What?
We are not able to see your slides.
Oh no. Let's try this again. We'll pretend like we didn't start yet. Okay, hold on. Hold on. Here we go. Let's see, where is that share button? We had it all set up. What happened? So strange. Hold on. Zoom Workplace. I don't see my share options. I'm so sorry. It is not showing me. Crazy. The share options have disappeared. So let's. Here we go. Nope. I'm so sorry. It's asking me to rejoin the meeting.
Yeah, no issue.
Let me just go back into the link because I'm not quite sure why I did that. But I don't have a share. I can't see the share option for Zoom right now.
If you take your cursor down, can you see that or not?
No.
No. Okay.
Here we go. Let's try.
Yeah.
I found you. Okay, now we're going to be golden in just a second. Here we go. Oh my goodness, that was painful. Let's try this again. Hi, welcome back. So on the second version of this, we are going to say hello again. Can you see me?
Yes, perfect.
Yes, all well.
Okay. All right. Let's try this again. Take two. All right. So we talked about disclosures. So this is important. We're going to start with the basics. I've already told you this. The real question here is we can fix it, but should we fix it? All right. So arthrogryposis encompasses about 400 discrete diagnoses. They all can lead to arthrogryposis multiplex congenita. 150 so far specific types of arthrogryposis have been mapped to specific genes. This is just the beginning. We've been doing a ton of research in the genetics and are identifying new genes every day. We just don't know their clinical significance. Arthrogryposis can be broken down into two broad categories. Amyloplasia, which is then you'll see a hemangioma on the face. You'll see the upper extremities and lower extremities are affected, but we do not have a gene for this, which is so remarkable to me. Distal arthrogryposis has multiple genes, and almost always we can find, not always, but almost always we can find something that is connected, and at least we can find an abnormality. Arthrogryposis is caused by fetal akinesia. This causes increased connective tissues around the joints, which leads to some of the issues. I just got back from Montreal at the 4th International Symposium on Arthrogryposis. This woman here who said little progress in prevention, but many significant improvements in management. Judith Hall is sort of the godmother of arthrogryposis. She's a geneticist who took a very specific interest in this syndrome. So this woman, Misha Dreamwalker, is another absolute amazing human being. So this car, she drives across countries and stops in all sorts of places to bring awareness about arthrogryposis. She has arthrogryposis. She posts on Facebook all the time. This is her fabulous husband. And she tries to tell people how to live a full life, happy and successful in her body that has many limitations. So really, arthrogryposis is not about what we can do for the patient. It's about what we can do with them. So I do a race that has a Ninja Warrior course. And I really see the fruits of my labor. Alone, we can do so little. Together, we can do so much. This is really the time that we are going to bond together, developing a treatment plan. I can do a lot of surgeries on these kids. They have contractures everywhere, but it's not always what surgery you can do. It's what surgery you should do for what patient and at what time. So communication between the team members, and I'm going to show you how big my team is, and the families particularly, as well as the patient, help guide our treatment. So you have to figure out what is on your problem list, what needs to happen first, what interventions do we predict over the next few years, because we really don't want to do surgery kind of like we try not to do birthday CP surgery. What life events are coming up? Are they going to start school? Are they in a wedding? Do they have a big birthday coming up? Don't do surgery then. So we also need to collect data, look at our outcome measurements, and do really good physical exam metrics to make sure we are doing the right thing for the right patient, and really need to maintain a very holistic approach. So where things started at Nemours, this is the legacy. In 1986, Dr. Jay Kumar and Dr. Richard Bowen thought of this vision for an AMC clinic, and it's a multidisciplinary approach to patients. They were really ahead of their time. And you can see this is our team of people involved in taking care of my patients. And we all work together. We are actually in a clinic together at the same time. So the goals of treatment aren't my goals, like I said. This is the goal, like Mary, she wanted to jump, and it took her a while to do this, but she wanted to jump like the other kids. And after her foot surgery, and she did have a hip surgery about 3 months before this, this is what she was able to do. This girl on the right, she had Escobar, she had spine surgery. She begged me to lengthen her leg. I thought that is the craziest thing I've ever thought of doing, but she did not want to wear a shoe lift. So in arthrogryposis, I don't think about lengthening legs in a tight structure. But with her, she asked me to do that, and I did. And then she asked me to write a letter of recommendation to my undergraduate college, which was called the University of Virginia. And she actually got in there, and she goes to the University of Virginia. So when we bring this team together, we want to maximize the function of each of these children and promote independence through a lifespan. When they walk into my clinic at 2 months of age, I am thinking of how are they going to get to college? So we really should start with the basics because, not everybody has seen multiple children with arthrogryposis. So here's a little bit of the typical involvement. So here's a baby with amyloplasia. Elbows can be extended or flexed and often can be asymmetric. If you think of a Barbie doll, sometimes they have a flexed one arm and a straight elbow on the other side. The knees can be extended or flexed, more commonly flexed, but those extension ones are really tough. And they can be asymmetric too. You have to watch the spine for increased lordosis, scoliosis, and especially a tethered cord, which it can re-tether. The jaws are very small, retracted, and sometimes need some help. And we don't stop there. The feet are often involved with, about 80 to 90% have either vertical talus or more commonly clubfoot. And the hands, most wrists are flexed and pronated, but it can be the opposite. Shoulders are usually internally rotated, especially with amyloplasia. Hips can be anywhere, and they can be in or out. So when we watch the spine, sometimes I'm focusing pretty heavily on the lower extremity, and I have to remind myself that the spine is actually attached to the hips, which is part of the lower extremity. So that's something I get counted in my clinic. But more importantly, these curves often rapidly progress. So if you're not looking at the whole patient each time, you could miss a rapidly progressing scoliosis. These hips can be very difficult to reduce. And there's a lot of controversy on who gets a hip reduction. Certainly, the unilateral should be reduced, and there is some controversy over if a bilateral hip needs to be reduced. I think hips should be in the socket, but that is not for all patients. So contractures of the hip present in about 90% of these AMC children, and dislocations are seen in 30 to 40%. And just to let you know, she had a hip subluxation. The knees, you often see this little dimple in the front. They come in varying severity. They're either extended, like I said, or flexed. The knee can be dislocated. The patella can be dislocated. So they come in all shapes and sizes. This was a study done by Merquenda out of Iowa. He succeeded Ponseti, and he showed that you could use the Ponseti method to work on kids with arthrogrypotic club feet. So clubfoot is much more common, but I treat them the same as a typical, although I have to make some modifications in my casting protocol. And sometimes, it doesn't work. But don't worry, give a girl the right pair of shoes and she'll conquer the world. So age matters too when treating arthrogryposis. So when we see this newborn, even in the NICU, it's a time of significant growth, and we can capitalize on the opportunities for gaining flexibility. Their tissues are very stretchy, but we also have to manage that with balancing the medical issues, feeding, positioning, and often, I don't know if it's the same in your NICUs, the positioning of the hip should be up and out. A lot of times they try to swaddle them. I really try to discourage that. They're also, as far as I am concerned, a lot of the medical doctors are not as comfortable with examining the musculoskeletal system. So, it's not unusual to find a hip that's been dislocated for a while, and they may not have understood why that hip didn't abduct at all. So I really encourage a lot of therapy and splinting. Even if I can't cast them at this time, I encourage the caregivers to learn to touch the baby, to stretch any way they can, because I think that keeps the soft tissues moving. And this may be a time that we do small surgeries. We do a little plantar fascia release. We do an Achilles tenotomy if we've been able to cast, but I don't do anything huge. And some of these kids can sustain even the upper extremity and lower extremity. She's smiling here, but she definitely wasn't smiling all the time. So I do, in the infant population, I do a lot of serial casting. I am lucky to have a physical therapist who will often accompany me in my clinic so that she will do all the hard work and stretching for even an hour session, and I will take all the credit after the cast comes off and the foot and arms look better. We might do tenotomies there. I've also been doing, for the extension contractures, I've been using ultrasound and the needle, the bevel of an 18 gauge needle to address the quadriceps very early, usually at the same time as the Achilles tenotomy. That seems to be very effective. And we don't wait too long for addressing the hips when they're medically stable and we feel like they are okay to go to the OR. We'll either go early or we'll just leave them and go when we can. Obviously, I've said before, I monitor the spine. So these are two of my arthrogrypotic patients. I really do try to promote a lot of camaraderie so they can see kids that look like each other. So in this period of time, I'm really considering school, sports, work, vacation, serial casting when I can. So I may serial cast every few months when they're babies, but at this time, it seems to slow down because the foot and legs are not growing quite as rapidly at most times. And so I'll use these casting periods as short bursts. And every time they have a growth, they have a growth spurt, I will use that as an opportunity to look for a new brace. But remember, it's not a fail if they relapse. Relapses are common. It doesn't mean you have to rush to the OR because arthrogrypotic tissue heals with arthrogrypotic scar. This is one crazy kid. This child was 18 months old when he was on the scooter. The pediatrician, when he was born, said he will never walk. And clearly he knows how to walk. My 18-month-old could not have done that. So these kids are pretty remarkable. So as they move into adulthood, we are constantly thinking, how are they going to get to college? How are they going to drive a car? How are they going to live independently? Because we need to maximize function. And if you could see on the bottom, I was playing hockey with this child, Nate, and I'm very competitive. And I told him that, I made sure he knew that he did not score. And then I scored on him and the news was there. So they videotaped us and put it on the news. And I felt so guilty, but he came into clinic the next week and he said, "Don't worry, Dr. Nichols, I let you score." Such a turkey. Anyway, so when we get into the late teen and adulthood, pain can be a problem. I really encourage them to make sure that their braces are good because they're not going to be able to be treated at Nemours after a certain age. I really push for healthy weight, regular exercise, and encourage energy conservation. I promote vitamin D and healthy eating as much as I possibly can. So the goal of treatment is build the basics for the future: eat, sit, and stand. This young woman is a music therapist, so she helps kids from at all ages doing music therapy to help them emotionally and physically. She has been through a lot herself, but is just rocking this world. Sometimes we try to guide our treatment and give some predictions to the families using this chart. This is done by Renee Donahoe and Dr. Bowen. And then, as I've said, we want to maximize function. I use physical therapy, whether it is out as an outpatient or just teaching families what to do. Physical therapy should be play at this age. It shouldn't be a drag. So between physical therapy, serial casting, bracing, we do a lot. Sometimes we'll do a gait analysis. Actually, I do it about every 6 months. And then eventually we have to go to surgery. So how do we reach our goals? We work hard. So let's look at the feet. So when this little guy comes in, you're thinking, oh boy, this is crazy. And historically, most of these kids were thought to be resistant to non-operative management. So casting or splinting followed by a PMR in about 50 to 90% of the cases. Subtalar release and telectomy was the go-to. I really don't do it this way. I have done a few posterior medial releases recently, which I just do not care for, but I know sometimes I have to do that. But the results of surgery for these PMRs were really pretty inconsistent when the average good results were 50 to 60%. And, we anticipate a stiff foot, but these were really stiff feet. And despite this, the most radical surgery to get the foot aligned, they often had recurrences. And that's one of the things that keeps me casting, is that even if you do these big surgeries, you still have a chance of relapse. So what I am trying to do is get a plantar grade braceable foot with 20 to 40 degrees of abduction and 5 to 10 degrees of dorsiflexion, not quite as much as the typical. So the question is, can we do it? Well, I think Merquenda showed me in one of his studies that he could, and I visited him a few times, so I really like that guy. And I would say that we can do this just with simple casting. We may need to change our techniques. We need to really concentrate on mobilizing the soft tissues. I do the Ponseti casting method, but as Van Bossa said, sometimes the equinus is so severe, you may consider doing an early Achilles tenotomy. And you need to adjust your casting method. So sometimes you really need to work on the supination maneuver. You need to try to pull out that atypical plantar crease. You can use this 4-finger technique, early Achilles tenotomy, and then in your bracing, you may have to be a little creative. So did we do it? I would say that's a pretty good win there. Yahoo, I'm happy. Sometimes you can put them in a Ponseti brace. Not all kids can go into a Ponseti brace. Now, sometimes you do get a really ugly foot. And I will just tell you this from an article. I swear this is not mine. But when you see this red, angry foot with a very deep crease, whether you have the deep crease and it's not a complex, well, this looks pretty complex after, even if it was atypical. But if you see this very angry foot, don't progress. Stop casting. And I would tell you, you need to take a deep breath and think about how these tissues will respond in this time of inflammation, not well. So we need to let them rest. And so often what I'll do is I will put them in what we call an aquaplast cast or splint. So we'll manufacture that here with one of our physical therapies. We'll maintain what position we've gotten with casting. And then, well, and don't think this little girl always smiles like this. She definitely does not. But she also had a dislocated hip. So we needed to get her feet to be in a good position so we could cast her after hip surgery. But she really did come around nicely. And we looked at this in an article to see, okay, does this serial casting, instead of doing quick posterior medial releases, really work? And it did. It really delayed the need for doing any surgical interventions. I don't count, a small plantar fascia release or an Achilles tenotomy, but we did increase our range of motion and our brace tolerance. So we looked in 5 years to make sure, hey, was that just, the early results? And in these 117 children, we really did see that the Ponseti method was successful in maintaining this braceable foot. And although you may lose some of these patients after these 5 years to needing surgery, that's okay. So we then looked at it just recently in the 10-year outcome of the Ponseti method. How are they doing now? Well, they're stiffer feet. 8% of these children needed major bony intervention, like a midfoot osteotomy. 17% had plantar fasciotomies, and none had a full posterior medial release by the age of 10. So we showed that Ponseti method did maintain a pretty good foot. It reduced our surgical rates, and I think it's a win not to have to continue to go back into a foot that is pretty scarred down. It's scary. So Clubfoot in arthrogryposis is definitely not just the foot. This is that kid who was on the scooter. He, as I said, is crazy. Please do not let your children stand on 4 skateboards at home. This is dangerous in any home setting, but this kid's insane. I want you to meet Mary. So Mary was adopted actually from India 2 weeks before I saw her at this visit. She has bilateral club feet, right knee flexion contracture. Her left hip is dislocated. And so we had to decide what to do. Now, she was just adopted. So this is an important fact to know. If she's just adopted, I don't think that that's the time to start doing major invasive surgeries to her. They also lived quite a ways away, so I had to maximize the time when they came back to clinic. So remember, in hip dislocation, it's in 15 to 20% of amyloplasia patients. We really should, my tact is to address the knees and the club feet first. So here she is. First, I want to let you know, behold the power of casting. For me, I think this is a good example of what you can get when you think you look at a foot and say, no way, no how, this is not going to get better. So as I said, we always use as much physical therapy as we can to mobilize the soft tissues. We did 3 casts, and before the purple cast, I did a tenotomy, and this is the result we got. She had left hip surgery, and this is 6 months after her hip surgery. I promise you, I cannot do that even to this day. So she really makes me proud. But one thing really bothered Mary. She really wanted to be able to kneel like the other kids in school. So just recently, she was lacking knee flexion. And I thought this was pretty good. So I really didn't want to intervene, but she just wanted to be able to kneel, just like her friends. So we went ahead and we did a pretty extensive release. I used neuromonitoring in these cases. We do a large dissection on the lateral side. Dr. Feldman, I think, wrote a fantastic article explaining how we release the posterior capsule. We release really all the structures, iliotibial band, biceps. And you will notice that you have multiple interarticular adhesions. And this is a really pretty scary surgery, but you get pretty good results. The stick factor of these results can be a little bit challenging. It's hard work. So what happens in cases that you just don't get the foot flat? So I don't give up. I get tougher. You may just have to rethink things. So we'll do a formal therapy session. We'll do a number of casting ideas. I may do a short leg cast, and I usually do a fiberglass with plaster under it because I really want a good mold. You have to give some time after you put plaster on if you have the option of using fiberglass because it can get hot. And I want to keep them walking as much as I can because they do get weak. I don't do long periods of casting. I try to do quick bursts to manipulate the foot as much as I can, repeat the cast until we have a braceable foot and start again. And with every growth spurt, we expect a relapse, and it's a new opportunity to think about the casting or the bracing. So I'm going to introduce you to a few patients now. Sometimes you have to accept good enough. And for surgeons like myself, I'm a pretty type A person. So when I see my x-rays in the morning, I would really like them to be absolutely perfect, normal, like nothing ever happened. But that's not going to happen in arthrogryposis, and you sort of have to accept that. So here she's pretty happy. She was not always happy. Here she is cheerleading like crazy. I mean, look at this kid. She's flying high. But unfortunately, she started having pain after cheerleading. She had multiple casting sessions as a child. And really, we had maximized this over the last 4 years. We did AFOs, we did Ponseti braces, we did some minor surgeries to release her tib ants, her Achilles, her plantar fascia. I tried to coordinate those with some upper extremity surgeries that she had done with my upper extremity partner. but now we just cannot get her comfortable. Casting has not improved her foot. So at some point I have to say, I am not winning here, but she's only 7. So if I do an acute correction, I feel like I am going to shorten her foot and cause a lever arm dysfunction. I have some play in the foot still because she's young, and I know that a posterior medial release, although it's a great option, it is a struggle. The bones are already dysmorphic, and if I can do something else, I will. So I will not be able to stress enough the importance of planning for your surgeries. You need to plan for A, B, C, D, E, F possibilities happening, and you need to go into the OR with all of the data that you possibly can, because you do not want to be surprised. These are hard cases. I really do feel like that about every case I do. My residents and fellows have to come in with a written operative plan. We need to have talked about it before. It helps us all. Best ideas come from those maybe that aren't in the driver's seat, meaning the scrub techs might have a good idea, the medical students, the fellows, the residents. I believe that if we go into the OR as a team, we will have much greater outcomes. So in my preparation for her journey, I did a CT scan just to really have a visual on how this foot is behaving. And you can predict some of this, but your 2D X-rays are really challenging to look, feel, and touch. And you can see that you're looking at a lateral of the foot and an AP of the tibia. That's never good, but it's spun through the subtalar joint, and you can see that the thigh foot, the transmalleolar axis is very external, and so sometimes you see a twisting from all the casting through the tibia too. So we have a really fancy gait lab. So we do a lot of gait analysis, and you can see that she has significant dorsiflexion loss. And if you look at this lateral midfoot pressure, it is red on the pediobarograph. It is showing pretty high pressures, and on the medial midfoot, there is nothing. So we also have the benefit of having really nice long-term follow-up. So we can tell how she's progressed. She got a little better, but I mean, I think a lot better if you look from where she was to age 7. So I think we've made some gains for her. We are trying to get her off those red spots, and we're going to get more foot pressure. So in our gait lab, we look at range of motion. We look at our patient reported outcomes. We test for multiple variables, and we do foot pressures. So our pediobarograph gives us a dynamic view of what the pressures are under the foot, and we can really see the high pressures that may be causing pain and breakdown. And these are fun images to watch, and kids love to see their own gait labs. So when we prepare for the journey for surgery, we will do a final reevaluation in our multidisciplinary team. So we may need to talk again with the geneticist. We have PT, OT. We have neurology. If I need somebody to look at her spine, because I do not do spine, I will send them down the hall. Upper extremity surgery she's already had, so I may have to consider what kind of crutch can she use afterwards. Can she use a walker, or do her hands limit her? Have we exhausted serial casting? Yes, we have, and we're still having breakdown despite all of our best interests. Our gait lab confirms that we have pretty significant lateral pressures. So now we need to formulate a surgical plan. And for us, I really have to look at the rest of the family. FMLA is family medical leave. So can the families take off work at this time? Do they have enough social and emotional support? Are they going to be able to get back and forth to the hospital? And I know you have those same issues. So our journey was strong. This was a long day in the operating room. This was I did bilateral miter frames. There are different variations you can do. The Ponce-Taylor frame is appropriate too. But a miter frame gives me the freedom to correct the hindfoot, midfoot, and forefoot. But you can imagine the challenge of this on a 7-year-old girl. both feet for 4 different programs. So for me, in the operating room, I bring it all. So this is a really good example of a 3D model. When I was trying to shoot this, some of the pins, it was very difficult to tell from a 2D X-ray where things were going. So I could use the imaging from my C-arm and try to compare it to this 3D model. And it really helped guide the trajectory of my wire so I wouldn't get into the neurovascular bundle. So I have a motto: bring it all. Make sure you have researched, you've really been thoughtful. I just wanted to give you 2 interesting slides on how we work this miter frame. So we think of initially when we place this frame, we place a tailor wire, and the tailor wire is attached to the proximal tibia, and that keeps the talus attached to the tibia, and then the calcaneus moves separately. So we're moving through the subtalar joint. Once you get your varus correction, and we're also working on cavus in the forefoot, then we will switch the wire from the tailor wire that was going to the proximal tibia. We will now reattach it to the calcaneal ring in the middle. And so now the calcaneus and the talus are one unit, and we will be able to correct the equinus. Now, this was a neurogenic foot. This is not our patient. So just to tell you, there are 2 parts of this, and then we bring the foot up, and we are killing ourselves at this point, but don't worry. A breakthrough is a moment in time when the impossible becomes possible, because this child was impossible. But she came out with a good foot, and now I can see an AP of the ankle and a pretty good lateral of the foot. So I would tell you that this girl, she was on that journey, which required her to be fierce. Oh boy, she was fierce, and she was up for that task. So the funny thing is that she got home in cast and got up pretty much that moment. And this is the first time she ever walked without braces in the creek. So she was very proud of, very proud of herself. I can't get it one more time. And this is soon after her case. So she's running, so she's up on her toes. She's still a little internally rotated, but I think she looks pretty good. So this is another guy. He has Escobar. He has an Escobar variant. He's never put 2 feet on the floor. He lives far away. He has terrible respiratory issues. So we really have to look at the whole patient. So he's trached. He's got limited motion in his arms. He's had pretty significant spinal surgery. He has hip flexion contractures, knee flexion contractures, spinal deformity, upper extremity. So, and he is a funny guy. So we are going to have to take care of him. And again, you got to plan what you're doing. This is about as much motion as I got, which was unfortunate. And the other side did not look any better. And x-rays always look terrible. Thank gosh his hips were in, very varus. But success is never owned, it's rented, and rent is due every day. And I don't know that you're going to be able to hear what he says, but this is literally hours out of his cast into his braces, and he was so thrilled to walk. And he looked up at his adopted dad and said, "Dave, where are your tears?" Because he wanted his father to be crying with joy that he had walked for the first time in his life. So very exciting. And then he's, at the Children's Museum jamming it out to some tunes. So remember, our goal of these surgeries is to improve range of motion, give them ability to sit and stand. Now, not everybody can do both, but you have to figure out what they need. So this is the next patient. He presented as a 2-year-old. He had never stood on his feet. He had already had posterior medial releases. He has significant deformity, amyloplasia. From head to toe, there was really nothing that was okay. He had bilateral anterior hip dislocations. You can see this valgus moment in the left knee. He's kind of a mess. So these hips were really tough. You can see we get 3D models to evaluate this. And I just wanted to show you, he came back. We had casted him. We had gotten him braces. We had actually gotten him into a stander, which was super exciting. But these knees were terrible, and the hips were terrible. So we worked hard to figure out a plan, and we staged surgery to put the hips back in. And one of the things that you really have to make sure, this patient also comes from a distance, is that you can get them into physical therapy. And unfortunately, he did not do, for all this work we did, he did not do as much physical therapy as I was hoping. You know, he's got some motion there. His knee motion is okay, not great. He hyperextends quite a bit. So we put the hips in and really thought we got a pretty nice result. And we're very happy about that. But he got super stiff after surgery. This is just showing we do an MRI to make sure they're in. And then we came back to do the right side. We do a shortening osteotomy to make sure, and often we'll shorten quite a bit in the femurs. And again, this is the other side, 8 months post-op. Here he is. He's actually beginning to get some truncal control. But you see, what's important to notice is he's got pretty bad scoliosis. That's going to be a big issue, because if we stabilize the scoliosis, which has moved now to about an 80-degree curve, if we stabilize the scoliosis, he uses all of that trunk swing to get his legs to move. So this is a really complicated problem. And I just wanted to just share that with you. So we have to think about the whole patient. That spinopelvic parameter is a really big issue. If you stiffen them too much, they will not be able to sit. He has a hard time sitting. He likes to be on his belly, and he rolls around like a worm. So this is a 12-year-old, very complex patient. And the only thing I'm going to tell you about this is you can see by this very busy slide that he had a lot going on. And unfortunately, he's since had a respiratory issue at home, and he did pass away. But my goal was, he was breaking down in his wheelchair, and he just needed to be able to sit in that wheelchair. So every patient has to have individualized goal setting, and you need to maximize the function that they have. So we released his knees so he could sit. We addressed his feet, and we tried to get him in the best sitting position possible for the wheelchair. We did early motion, so you can see he has a short leg cast. I will often put a thigh cuff on and even use the hinges from an old CAFO to get them moving right away. So this is the last patient I will share with you. Again, not just one joint. This kid is awesome. He was 9 and he has a lot of things going on. He had a left hip that was reduced and is stiff as a board. He is in full extension on that side, really maybe has 10 degrees of flexion. He has a limb length discrepancy. He has feet that have stopped being nice to me. No matter how much I cast, they come right back. We've done some soft tissue releases in the past. So again, we really need to maximize the information that we get going into these surgeries. They are multidimensional. So I start from, I need to know what the spine's doing, the hips are doing, the rotational profile, the limb lengths, and then what is our goal at the end. And his feet look terrible. And so his feet were really rigid. Now, maybe in hindsight, I might say that I could see something on this x-ray that was unusual, but I think this is going to show you the importance of 3D imaging. So this is a rotational profile to help us make sense of all the alignment issues that this child has. And then, that goes too fast. Then I want to show you this, is that you can see that there's a little bit of an issue that both of these feet have a little bit of a connection that is not supposed to be there. So unfortunately, so with our CT imaging, we can just try to establish some relationships between each of these joints and the extremity. But of course, he opted to give me a little bit more fun. And in addition to all the other things I was going to take care of with him, he also had bilateral talocalcaneal coalitions. So, and with a significant varus of the heel. So, got to take care of that too in the same setting. but I'm glad I looked into that. So this is sort of a mini example of the extensive preoperative plan, figuring out what your problem is, what are you going to address now, and what is your plan for addressing it with your backup plan. And we talk about this pretty extensively and try to be as thoughtful as we can and make sure we have all the information before we go to the OR. Because when we put this big, huge frame on and we do all of our work, we want to make sure that what we come out with is a good thing. So at one point he had 5 different frames on, and they had multiple different programs going. So, but he is doing wonderfully. I saw him yesterday. He is pain-free. So I'm going to try to hurry up here. But in the adolescents, I don't want to put the frame on. They've gotten their full length of their foot. This girl also had multiple problems. She had a limb length discrepancy, foot problems, and she has a perineal nerve palsy just from birth, congenital. So her big thing was she hates her limb length discrepancy, and her feet were really bugging her. So what we did was we actually did a precise femoral lengthening on the right-hand side. And in this case, I do often dorsolateral closing wedge osteotomies to try to correct things. And then if I have to go to the tibia, I will also. She had finally gotten to the point where she was developing stress fractures in the 4th and 5th and just needed to have her foot realigned. So she's off to college. She's doing great. She actually is pain-free. I am concerned that I feel like she's gained a little weight, and I hope that, but she can run without braces. That's pretty amazing, even though she has no perineal nerve. And in braces, she's looking, I think, pretty fantastic. So we look to see how these kids were doing after their foot osteotomies. I just presented this at the symposium. We wanted to look at their preoperative and postoperative gait parameters, see how their patient satisfaction and their pain was, with our goal of treatment is, as always, painless braceable foot. And I tried to wait to do osteotomies till later in life. And what we see in this research is that the conclusion was that they actually did very nicely in the short term after their osteotomies, without all of those intermittent surgeries before. So here's our take-home message. Arthrogryposis is not a one-size-fits-all diagnosis. You really have to cater your care towards the family and the patient and meet them where they are. And the same treatment plan will not be the same for every single child, but you have to think about how are we going to get these kids independent and living on their own, doing the fun things that they want to. Children grow quickly. Each time they hit a growth spurt is an opportunity to rethink the brace or consider a surgical intervention. Surgery do surgery when it's appropriate, start small, and then go big if you need to. Surgery can improve function, but it does not cure arthrogryposis. For future directions, we've done a lot with genetics. We do have genetics in our clinic. We work carefully with one of the universities nearby. They do a lot of musculoskeletal research. We're also sending things to the biobank. Arthrogryposis, I'm hopeful that gene therapy will work, but because it's an akinesia problem, it may not be the best arm for treatment. There are some kids that have a myasthenia gravis type gene that actually can be improved with medication, and that's a new advance. So I am collecting specimens now, and we're going to look at why, get really down to the basic science, because I don't think that surgery is going to fix this. I think figuring out what we can do to reverse the contractures and grow muscle will make a difference. So I just want to end with this. This is Grant. He is about the coolest kid I have. I have a lot of cool kids though. He's in a spica cast here. He just had his hip done. He has brothers. He is a hard charger, and he's gonna get there. And these kids have determination beyond what I can give them. But I try to believe in them just like they do. So here's my last.
Send this to my family.
This is his first day standing up.
That's amazing. Get that foot all the way flat. There you go. That's it.
This kid means business. So He really does like to hit it out of the park. We have a belief that they can do whatever they want, and this kid has shown me that he can absolutely do it. He has 2 older brothers, which makes a big difference. So Misha drives around this car, and she's amazing. And my physical therapist, who just loves her, didn't realize I had actually gotten my foot on the back of her car before she did. But I just like to make sure everybody knows that. So thank you so much for your time. And I hope we have a few minutes for questions. Here's my email address if anyone ever needs to contact me. I love this stuff. These kids are the best. Do you want me to stop sharing now?
Yeah, I stopped sharing that. So thank you, Reid. What you said, actually, you showed by the video also that trying to make these children independent is a very important goal, and how you achieve that. So we have a few questions. So let's start taking it. Ruchita, would you like to start taking the questions?
Oh, yeah, there's a question from Meet Jain. He says he wants to know what casting and bracing protocol is followed for the AMC club feet, and how is it different from the routine Ponseti?
So I start every kid's foot is a little different. I really do follow Ponseti to the T. So I do soft tissue manipulation first, lots of it. And sometimes I'll have my physical therapist work first. So I follow the same protocol. Now, if they have a very deep crease, so it's a very atypical foot, you may need to do the modified Ponseti. So I may need to do the 4-finger technique. You really have to, you just got to, it's not just putting on a cast. It is really paying attention to those fine details, feeling the foot. And then if the foot gets angry, stop. Don't keep pushing through. Give it a minute. Put a little splint on if you can, however you can make it. Hold that. Let them do a little physical therapy. Settle down the soft tissues. That was the best lesson I have learned in my career, is don't push through that angry foot. It just hurts you, it hurts the family, and it hurts the kid.
And 2 questions from me. Is there a lower age limit at which you would still try to do a bilateral AMC hip?
Is there a lower age?
As in,
Or-
if it was a really young child, would you try to intervene
Yes.
in both the
yes.
hips? So what's your cutoff beyond which
so-
you'll say,
so
okay, now
we-
no more?
No, gosh, sometimes it matters like if they have ZC4H2, they're funny kids. They can sometimes have weird reactions, dystonic things. So I'm a little bit more cautious in them. But if we're relatively aggressive about putting the hips in. So if they're medically stable, I'll be more aggressive. There's no right answer. After the AMC meeting, though, I will say I have 2 kids that had medial approaches other places. They're basically fused. I might recommend not doing it a medial approach. It does seem like the risks are much higher for AVN, especially in the AMC population. Hold on one second. I'm just going to plug this computer in because I don't want to lose you. Hold on 1 second.
So I'm glad to see
Okay,
plenty
sorry.
of questions are pouring in.
Yes. Okay. Go ahead. So I think there is no minimum age that I will do, but you do have to individualize because there are some kids that are pretty sick. We had one that's pretty complicated. We did put both hips in. They did have, and I use the slim nail, and often, I want to have intramedullary fixation because I'm going to do a lot of shortening too. And that's more for the, when I'm trying to bend the knees, actually. But be generous when you take away bone. I guess that would be my
So
other
you already
option.
answered my second question. So we'll go to someone else's question. What are your thoughts on growth modulation in fixed flexion deformity knee?
Oh, so for the fixed flexion contracture, if it's a small one, I do some anterior, either I haven't figured out which way I like it best. You know, was it screws, or they can grow off the screws, or if it's staples. 8-place I don't like in the front because I think they're painful. Van Bossa does it. He puts it anterior on the femoral condyle and kind of bridges it across. I don't know about that either. So whatever way you like to do it, I think I've had staples break before. But I think a small deformity, I'm all good for growth modulation. For a large one, I don't do, you know, if it's more than 30 degrees, I'm going to do a femoral shortening and do a big release.
Does muscle power around the hip and the walking potential influence your decision to operate on the hips? That's from Thomas.
Yes, I think that's a very good question. And you know, sometimes there's I can't remember his name. I just saw him, but he's from France and he did a really nice MRI study. And I've done a bunch of MRIs on them too. Not all the muscles are the same. So some kids don't have a gracilis. Some, like, things don't always attach where you would expect them to either. So yes, I think the muscle power is important. And you don't want to necessarily operate too soon if they're just about to walk or something. So I think it's a balancing act. I try to see what they have, and you have to be pretty tricky in your physical exam to make sure that they, you know, if you don't think they have gluteal muscles, you don't think they have the abductors, maybe they're not in the position to show you they do. There are times, and this is a little different, but there have been times that I have just casted a foot that didn't have a bit of dorsiflexion, couldn't flick their toes, couldn't do any ankle motion, just moving their foot out a touch, 5 degrees. All of a sudden, it must change the power tension ratio must change, and then they can move their foot. Not like, you know, not like you and me, but they can start to move. And then that continues. And I think they have to be able to neurologically tell the foot to go. So that part to me is so crazy.
There's one more question. I think it's a little related to what you spoke earlier, but what do you believe works more, posterior soft tissue release versus distal femoral epiphysiodesis? And the lowest stage for screw epiphysiodesis is what they want to know.
So if I am going posteriorly, I'm going to take out some femur too. What you see when you do these releases, it's not just posterior, it is intra-articular too. It is anterior. These things are socked down. And that's why I'm collecting these tissues, because I am pretty sure some of them just get like hard as a rock too afterwards. And that's very frustrating. But don't go do these surgeries unless you have adequate PT. They have to be able to get the PT, or it's kind of not worth it. You'll see how quickly things get lost. The youngest age that I would do a screw epiphysiodesis, you mean a hemiepiphysiodesis, I'm assuming,
yes,
anterior?
Yes.
Yeah. I just did one I just had one that somebody had gotten a growth arrest posteriorly in the distal femur, and I took out the bar, which was terrifying. Talk about bringing the kitchen sink into that OR. And I did put staples in the front, and she was 3, because I wanted to give a little bit more power to the growth plate on the front to hopefully pop open the back, because it was a relatively large physeal arrest. So, but she's 3. It's challenging.
And one more question is about the hip dislocation with extensor knee contracture. Surgery in the same sitting or in 2 sittings?
Probably for me, the same. But listen, I'm telling you this, taking them early as an infant, you know how well a tenotomy works.
Yes.
It works well. We have, so if I know that and typically they have a Clubfoot too, or something like that. So we have a day medicine, so they can get, you know, a little sedation, and I can take, I do often use an ultrasound, just because just because I haven't done it that many times. But I'll take the bevel of an 18 gauge needle and just disrupt the rectus. And I get flexion. And that flexion actually doesn't go away. So if you have the opportunity, now it's different when they're older, then V wide, like there's a whole bunch of stuff you got to do. And even then you're going to notice that you could do a big VY bit advancement, and you'll see that the patella often has like tentacles underneath it. It is just socked down. I think patellar motion gives you a lot of clues on how your knee is going to respond.
True. And one last question again from Jitendra Kumar is naviculectomy in a resistant clubfoot.
Well, I just did one. Not what I really wanted to do, but I really didn't have another option. I am not a fan of telectomies. I'll tell you that. I am not a fan of, if I can avoid doing a posterior medial release, I will tell you they are not satisfying to me, because by the time I'm doing them, they are older, and it is the bones are totally dysmorphic. I had a recent wound complication because I asked the foot to do too much. They didn't want a frame. They live across the country. They didn't want to do an X-Fix, and I knew that would have been the best answer. But that's what and I don't want to do big osteotomies. I did do a calcaneocuboid fusion too, but sometimes you do need to take out. I have taken out the navicular.
And one more from Dr. Mir Tariq. What's the post-operative immobilization protocol for AMC hips?
For AMC hips, we are still putting them in a cast, but for at least four weeks, sometimes 6. They will get stiff, but I think that it's important to get them to heal too. The knees, however, the reason why I often use, so I will refer you to the Feldman article in Journal of Children's Orthopedics. It is excellent. But the range of motion is really important. It's a balance between moving things and healing. So in the knees, if I do a femoral osteotomy and I do a huge shortening, I want to try my best to get an intramedullary nail down there, a rush rod, whatever you have, so that I can move them quickly. I will like I said, I'll take a hinge and put it on the sides and put it in the cast. I am working on a CPM machine for small children so we can get them moving, because you can lock them up in extension if they had a flexion contracture, but they will get locked in extension. You can lock them down in flexion, but they will get locked in flexion. So you have to do both quickly.
So I think it's been really good. We've had a lot of discussion because the number of joints that we covered were quite extensive. And I can still see people are still glued in, although it's now getting closer to everybody's bedtime. So thank you so much, Reid, for really sharing wonderful experience of so many years with us and stimulating some more thought as to how we could really optimize our therapy regime and maintain mobility for them and begin early and make a holistic plan for these children. So
and just remember, it's not what you can do surgically, it's what you should do and when. Because right. I will tell you, you look at any of these patients, your little surgical mind says, I can fix that, and that. But I did do a study a while ago looking at gait labs 20 years out. The kids that had more casting than surgeries, their gait labs were almost identical, if not a little better. The ones that didn't have as much surgery. So just consider that. And holistic approach, include the family, work to independence. And they are the coolest kids ever with very high IQs.
Yeah, true. So on behalf of the POALS team, Dhiren, Posey, and the OrthoTV, and everybody who's tuned in, thank you so much, Reid. And maybe we can have one more from her at some point about her wonderful hallux varus theotomy.
My bunion surgery.
Yeah,
that's right. That's a fun one. That's a really fun one. Well, thank you again. I love talking with you all. And if anyone needs to ask me more questions, feel free to email me. I love to talk with you. All right. Have a
Okay.
wonderful day. Thank you. Thank
Yeah,
you.
thank you.